So I'm very pleased to introduce to you today Dr. Laura Feemster. She is an associate professor at the University of Washington Division of Pulmonary, Critical Care, and Sleep Medicine, and core investigator at the VA Puget Sound HSR&D Center of Innovation for veteran-centered and value-driven care. Her research focuses on improving access to specialty care and increasing evidence-based care among patients with COPD. So a particular expert for this focus of our lecture today. She receives funding from the VA, from NIH, and the American Lung Association, and she's going to be talking with us today about optimizing COPD care for older adults. Welcome, Dr. Feemster.
Thank you so much. I'm really happy to be here. I was excited to hear about this lecture series and to hear some of the lectures that you talked about. I'm going to check out the website, but I appreciate being here today with all of you. It's a little bit of a different format than I'm used to. I know you all are used to the webinar. So Barb has promised to monitor the chat for me and let me know if there are questions that come up as we go through. I would be happy to answer them during, if it's most appropriate to do so, and she's going to give me a heads up about that. Otherwise, there should be plenty of time at the end for questions. And with that, we'll get started. This is my disclosures. I think Barb mentioned my funding sources. I'm also an associate editor for a journal as well as a consultant for the NCQA, and my obligatory Department of Veteran Affairs disclaimer is there as well. I think those of you who have signed on and know the objectives of this lecture, but I thought it would be good to review them. We are going to have a little bit of whirlwind of COPD care. I'll give you the outline next, but by the end, I hope that you can identify evidence-based dyspnea management strategies that improve outcomes and quality of life for older patients with COPD. And with that, review inhaled medications used to treat COPD with attention to common barriers to adherence and potential adverse effects for older patients. And then discuss the potential impacts of non-pharmacologic therapies, including pulmonary rehab and oxygen therapy, and how they can help, and in the case of oxygen, sometimes impair mobility for older patients with COPD. And we'll talk about that. So we're going to talk in sections. Like I said, it's going to be a general overview of COPD care with a focus on primary care, and we're going to highlight special considerations for geriatric populations. I'm going to start with the background, talk a little bit about diagnosis, smoking cessation we'll cover briefly, and then we'll spend the bulk of the time talking about exacerbation prevention and symptom management, including comorbid condition management, as well as pharmacologic therapy for COPD, pulmonary rehab, and oxygen, like I talked about. I think it's important just to sort of set the stage for all of us to recognize the burden of COPD in the US. It affects 24 million Americans. You can see here broken down by age groups, and men and women, and obviously it increases with age, the prevalence, so that in the 75 to 84-year-old age range, 11% of men and 10% of women are affected by COPD. It is in fact the fourth leading cause of death, moves around between third and fourth, but currently the fourth. And the mortality rate from COPD, unfortunately, has increased over time. Between 1980 and 2014, it increased by 30%, while the mortality rates from many other chronic diseases, as we know, have improved over the same time. COPD is responsible for more than 700,000 hospitalizations per year. This was a recent study that was published that demonstrated that, unfortunately, over time between 2001 and 2012, when you look at other common conditions and adjust for age, you can see that hospitalizations for things like congestive heart failure and pneumonia and coronary artery disease have decreased over time, but the hospitalization rates for COPD have remained fairly stagnant. 30-day risk standardized mortality is somewhere around the range of 6 to 14% after a hospitalization for COPD, and the readmission risk is high, 17 to 28%, depending on the study. Obviously, this healthcare utilization leads to costs in a number of ways. One of them is that estimated days of absenteeism per employed adult with COPD is probably about 3 days per year. And there are associated costs that are close to 4 billion per year for patients with COPD. This is a chart of inpatient costs, and you can see again that costs overall for the whole group. And as you break it down by men and women, if you break it down by age group, it's the 65 years and older for all the groups, as well as the men and the women that are bearing the brunt of these costs. So obviously an important problem for this group of people. This article in European Respiratory Journal that was published in 2011 gives us an idea of what the burden of COPD is like for patients. You know, this was a cross-sectional study of 2,400 participants that were over the age of 45 who met criteria for COPD and had the obligatory tobacco history, as well as some spirometry characteristics that diagnose COPD that we'll talk about. These patients actually had severe COPD, had severe airflow obstruction, and had no exacerbation in the previous 3 months. So somebody who's stable, but with severe airflow obstruction, and they assessed their symptom variability and their impact on their daily activities. And you can see that 83% of participants had trouble just going up and down the stairs in their home. 57% had a hard time just doing their household chores, but a fair number also had difficulty doing things like going shopping, 43%, and 36% doing sports and hobbies. So clearly very impactful for our patient population. And unfortunately, I told you hospitalizations aren't improving over time, and neither is mortality. And paired with that is that the quality of care for COPD has historically been pretty poor. Only 1 in 3 patients receive spirometry for diagnosis. And these are studies that I'm quoting here back from the early 2000s. And you'll see hasn't changed much since, but only a third of patients are receiving appropriate diagnosis by receiving spirometry or oxygen therapy if it's indicated, or appropriate pharmacologic therapy. 63% receive smoking cessation, but only 19% receive pulmonary rehab referral. And so these are going to be some of the things we'll be focusing on in our talk today. And this is what I hinted at before, that if you look at more contemporary literature, these are studies actually that our group has published in as recently as 2020 in CHEST, and in 2018 in a journal called COPD. We still found only 1 in 3 patients were receiving inhaled therapy per the guidelines. And in the hospital, the care continues to be similar, where only 18% of patients that are admitted to the medical ward with a COPD exacerbation get ideal care, and only 40% of patients admitted to the ICU receive ideal exacerbation care. So it really emphasizes the need from a research perspective for behavioral interventions to improve care quality, but as healthcare providers for us to also concentrate on improving care quality for patients with COPD. So with that, I'm going to talk about first diagnosis. And I know this is a multidisciplinary group, and so I thought it might be helpful to cover both just what are the criteria for spirometry, but also talk a little bit about what is actually involved in the spirometry procedure, because I think it helps you understand why it might be particularly difficult in an older patient population to make an appropriate diagnosis. So a diagnosis of COPD, and this is based on GOLD guidelines, which you might have heard of, but also American Thoracic Society and European Respiratory Society guidelines. It requires that you have fixed airflow obstruction, which I'll demonstrate what that is. And we meet criteria by either having a forced expiratory volume in 1 second over a forced volume in 6 seconds of less than 0.7, that ratio, or it can be calculated based on what a predicted lower limit of normal would be, and if you fall below that lower limit. And different guidelines advocate for different cutoffs, but both of them are different ways to define this fixed airflow obstruction. And a lack of spirometry leads to both under and over diagnosis of COPD. So this is from the GOLD guidelines, which is one of the major guidelines for patients with COPD, and this is talking about an algorithm for diagnosis. And so the recommendation would be that COPD should be considered in any patient that has symptoms and a history of exposure to risk factors. And the symptoms that we most commonly see of COPD that many of you would be familiar with is persistent shortness of breath, particularly with exertion, chronic cough, chronic sputum production, and chest discomfort and tightness, which sometimes can be a little confusing as to whether or not that's a symptom of COPD or comorbid cardiac disease. And so that is always in the differential. But when sputum production and cough and dyspnea are involved, those are the most classic for COPD. And it should be in the setting of appropriate risk factors. In the United States, as you know, it's going to be tobacco smoke. The threshold is usually 10 pack years, or the equivalent of 1 pack per day for 10 years. In other countries, things like indoor and outdoor air pollution, occupational pollutants also play a role. Family history, so alpha-1 antitrypsin deficiency can increase your risk for COPD, and older age are all risk factors that you should think about when screening for COPD. And when you find a patient who has the appropriate risk factors and symptoms, again, it's spirometry that we want to do to make the diagnosis. And as I said in the previous slide, it's defined either by this fixed cutoff of 0.7, or you can use the lower limit of normal. This slide just highlights the importance of underdiagnosis and overdiagnosis. Both are a big problem. 50% of cases in the US are probably unrecognized. And there's a number of reasons why that's so, but some of them have to do with barriers to getting spirometry done. This is barriers to spirometry in the absence of COVID, which I didn't add to this slide, but has added additional barriers that have made it challenging over the last couple of years. And we can talk a little bit about that in the question part if people want to. But the barriers to spirometry that are always there is the access to high quality testing may not be as good as it should be. A lack of recognition of symptoms or atypical presentations can sometimes lead to a lack of spirometry being performed. There's also some degree in some studies, and this was a qualitative study that Min Ju from Chicago published, is that sometimes there's a lack of clinician buy-in to the importance of spirometry for diagnosis. There can be a perception that you can diagnose COPD without having spirometry to confirm it. And as the pulmonary community, we would highly recommend the spirometry gets done because it's not uncommon that it's misdiagnosed without it. Overdiagnosis is also a problem, though. The BOLD study is a multi-country study that's conducted in 23 countries between 2003 and 2012. It's an observational study that looks at different populations and has more than 16,000 participants. 6% with a diagnosis of COPD, but 55 to 62% were found in a subset to have no airflow obstruction. So there's both the problem of underdiagnosis as well as false positives for COPD, which gets again at this lack of spirometry being done. So some of you may have done spirometry before, conducted spirometry for your patients, or witnessed it, but I think it's important to talk through it, especially when thinking about the older patient population, because it's not the easiest test in the world to do. It's not the same as getting a CT scan and having someone just go through a CT scanner. In fact, there's a lot of things that go into it, including the correct positioning of the patient, as well as the correct performance of the maneuver, which can be difficult for young, healthy people to do appropriately and can become even more challenging for our older patients to be able to do. Basically, a participant has to sit upright in a chair, make sure their feet are on the ground. They have to put a nose clip on their nose so that they are only breathing in and out of their mouth. They have to be able to then hold a tube like the one you see here, in their mouth with their lips tightly sealed around it, take a deep breath in to full capacity, hold their breath until you instruct them to breathe out as fast, as hard as they can, without any hesitation, without any cough, and without anything going wrong. And they don't have to do that once. They have to do it at least 3 times, and they may have to do it up to 8 times because you need it to be both acceptable and reproducible. And so you can imagine how someone with lung disease, that's already not the easiest thing to do. And if you're older and have difficulty with hand manipulation or finger or hand strength and finger strength or tremor or something like that, it can be a real challenging test to perform. When it is performed, these are spirometry results, which I think is a little bit helpful to think about those definitions we were talking about before. This is a flow volume curve. So there's an inspiratory limb, which is here on the bottom, and an expiratory limb. And I tried to draw in a normal curve, which is probably not exactly the way it would look, but it's close. It's pretty close. And then this is an obstructive curve, and it has this very classic, the patient starts to breathe out and they get this very scooped looking obstructive pattern. And so that's what we're looking for when we're interpreting the spirometry. And the numbers become this jumble of numbers that you see on an printout. But the things that I look at first is I look at first their ratio, which is that forced expiratory volume in 1 second over the forced the FVC, the forced vital capacity, which is how much they're able to breathe out in 6 seconds. And you're looking again for that ratio. So this patient who has airflow obstruction has a pre-bronchodilator measure of 48% and a post-bronchodilator measure of 41%, which sometimes happens, sometimes it goes down. Meets airflow obstruction criteria, both by the way it looks as well as both if we tried to use a 70% as our cutoff, or if we use lower limb of normal, this person has airflow obstruction. And then the next thing you look at is their FEV1, which is that forced expiratory volume in 1 second. And you look at their pre-measure, which in this case is just over a liter, 1.13 liters, which is 37% of predicted. That is in the severe airflow obstruction range, which we'll talk about in a minute. And then we give them albuterol. And we see when we repeat the measure what their post-bronchodilator albuterol is. I already told you the ratio was 41%. In this case, they had some improvement in their FEV1, and now it's at 45%, which is still in the severe range for you to know. But they had a pretty significant bronchodilator response. They had a 20% change in their FEV1 between the two. And so if you got a readout from this, we would read this as severe fixed airflow obstruction, because they have airflow obstruction both before and after bronchodilator, and it's severe in its range. And they have a bronchodilator response, which doesn't mean a whole lot in COPD, other than to say that we should be using this post-bronchodilator measure as how we rate their severity. It doesn't mean if they don't have a bronchodilator response, they shouldn't get a bronchodilator, which I think can be somewhat confusing. But so it shouldn't dictate your treatment. It's just something that you'll note in the read of the report. And so this person has severe airflow obstruction, like I said, and that would be confirmatory of a diagnosis of COPD in somebody who had the right risk factors and symptoms. So I hinted at this a little bit, but one of the issues is that there are barriers to high quality spirometry among elderly patients that we should think about both when we're ordering these tests and when we're performing them. I talked a little bit about motor and sensory deficits, the lack of dexterity, and the ability to hold your breath and then breathe it out in the way that we need you to can be more challenging. There's also difficulty in the coordination and the sequencing of the maneuvers. If the patient has significant cognitive impairment or dementia, it can be pretty hard, as you all know, to learn and then recall the instruction, and they might not be able to interact with the technician as they need to do it. They can also have other factors and other conditions that are contributing, such as depression, which might make their motivation less than optimal for the test, and they can be deconditioned or have malnutrition, which makes it really hard to get these reproducible and acceptable tests. I think it's important to remember those things, but I think that there are actionable things that we can be doing to improve the quality of spirometry for this patient population. Because as I said, it is really important that we get the diagnosis right. And those things are that there are environmental and technician conditions that can be improved. And so having a technician that has geriatric expertise is really important, because they can then know to use visual tools or other things that can help the patient get the testing done appropriately, and they can tailor the teaching process to what the patient needs. And then they can also work on making the environment as comfortable as possible for the patient, because an unpleasant or stressful environment that doesn't appropriately adjust for maybe needing a little more time to get this done, or doesn't gently repeat or break up the steps into the maneuvers into various steps that make it easier for the patient to complete as they could, um, can make the test not be of any use. And so it's really important for us to remember that and to try to improve the quality of the result. And this is all from a great review article that's in the European Journal of Medicine from 2014. Okay, so that's all I'm going to say about spirometry for now. I'm happy to answer more questions about it later. It's impossible to give a talk about COPD and not talk about smoking cessation. I think this is a topic that we frequently address in various venues, so I'm going to spend not as much time on it now, other than to say that there are special considerations to take into account for the older population, and also that it is the one thing, if there's only one thing you take away from this lecture, it is the one thing that consistently improves mortality in COPD. And so really we can talk about the medications and getting the right medications on board, but the most important thing is to get patients to quit smoking. And so with that in mind, I wanted to talk about at least one article that was published in 2019 that looked at the state of affairs in 2015 and found that in the US, estimated 4 million older adults over the age of 65 still smoked, and that it emphasizes this idea that quitting smoking at any age has benefits. Even at age 80, it reduces your risk of dying from cancer. And among those who are diagnosed with cancer, quitting smoking still improves prognosis. And so it's never too late for patients to quit smoking. And so I know it can sometimes be challenging for me when I've presented smoking cessation over and over to the same patients, but I think it's important to remember that that it is important to address this every time we interact with them, no matter what our role as a clinician is. And unfortunately, rates of smoking cessation in patients over the age of 65 fell 2% over 10 years, as opposed to 27% overall. So it only improved by 2%, as opposed to 27% improvement in smoking cessation among everyone else. And so in this study that was published in 2019, they took a sample of 8,000 patients that are 65 and older, and they looked at who was a current, a former, or smoker, or a never smoker, and found that there was a fair number of participants over the age of 65 that were still currently smoking. And I think the thing for us to take home from this is that among those patients who continue to smoke over the age of 65, that 54% of them were interested in quitting, and nearly half had made a past year quit attempt. And 66% had received advice from a healthcare provider about smoking cessation. So there's a little room to go there, like we had talked about in the beginning, of still not emphasizing smoking cessation maybe as much as we should. But only 6% had gotten counseling and medication. And the smoking cessation pharmacotherapy with either nicotine replacement therapy, bupropion, or varenicline is really part of this, and something that we should be recommending for all our patients. And that's where I think we're still kind of falling a little bit short. I think there are great resources, because smoking cessation in older adults probably takes a little bit of a more tailored, more intensive intervention based upon the literature. And this is again reviewed in that same article. And so emphasizing during counseling that even older patients can still derive substantial benefits from quitting. They can still succeed, which I think is one of the things that I often see, that patients have tried so many times before and they might not have been able to quit, but they can still succeed. And they're more likely to be successful if they've had prior quit attempts. Um, and that chance of quitting is substantially increased if they used evidence-based tobacco treatments. And there's good literature to suggest that even if a patient doesn't say that they're currently willing to quit smoking, and I can provide this link to you guys afterwards, but providing proactive nicotine replacement therapy actually improves quit rates so that they have it available at the time that they decide that they want to quit smoking. There are other resources, some of which are shown here, and programs that buddy support programs and age-tailored self-help materials can improve cessation rates in those over 50 as well. So just important to remember that those things are there. Okay, like I said, I wasn't going to spend tons of time on the smoking cessation, but I think we can talk about that as more later as well. So the brunt of this is going to be talking about treatment of COPD. And really, when we're talking about treatment of COPD, we're talking about exacerbation prevention and symptom improvement. And so before we get into that, I think this article in JAMA in 2012 is a nice review reminding us about increased dyspnea among older patients with COPD and the diagnostic considerations that we need to be thinking about. And the issues are that they have COPD, but they also are more likely to have a number of other things going on at the same time that make their shortness of breath multifactorial. And we should continue to remember that at each of our interactions. And so some of that is that they have patients with COPD in general, but particularly older patients, have high rates of depression and anxiety. They can have high rates of social isolation because they're not functionally able to do what they once were. And so, for a number of reasons, they get isolated in that setting, in addition to having their depression and anxiety. All of those things can play together to increase their sensation of dyspnea and decrease their adherence to inhaled medications, which can then worsen their shortness of breath. They have reduced ventilatory capacity for a number of reasons, including obviously their COPD, but also other comorbid conditions that you see listed here. And ones that I highlighted are things such as osteoporosis leading to kyphoscoliosis. That makes it difficult for them to breathe in addition to their COPD. They can develop pulmonary hypertension over time, and they have high rates of comorbid cardiac disease, including heart failure. And so addressing those comorbid diseases and teasing them out from the COPD becomes a really important part of COPD management. In addition to their reduced capacity, they can have increased demand because of heart disease, but also because of anemia and sarcopenia, muscle wasting that happens over time in the setting of COPD and advancing age. And then there's a number of environmental factors that can worsen their shortness of breath, such as the exposure to ongoing secondhand smoke. And if they're in a situation like I talked about earlier with stairs that they have to walk up every day, they can just be in challenging places. And so this helps emphasize the importance of not only treating and optimizing their COPD specific therapy, but treating their comorbid conditions. And all of the guidelines have sort of incorporated this into them over the last couple of years, highlighting the importance of treating comorbidities among patients with COPD. So we're going to talk about the approach, the evidence-based approach to managing dyspnea for older adults with COPD now. The first thing that we'll talk about is pharmacologic therapies. And I listed here, this is again from the review article from JAMA in 2012. COPD inhaled therapies have the strong evidence in multiple randomized trials, and we're going to talk about which inhaled therapies should be given. But I think it's important to remember as we talk about these that most of the trials excluded patients over the age of 80, and that non-adherence, both intentional non-adherence and unintentional non-adherence from being unable to use inhalers appropriately, can occur more frequently in older patients due to impairment. And then also because adverse effects from these medications may be higher in this patient population. So we'll talk about those considerations as we move through what those inhaled therapies are. I'm then going to talk a little bit about opioids for the use of refractory dyspnea. There was some recent American Thoracic Society guidelines that speak out to this in particular. And so we'll talk about the use and the evidence to support them and when to think about using them. But it is important, as you all know, to think about the adverse effects of opioids, particularly among older adults, including the things you see here, such as constipation and urinary retention and confusion. Although these have been studied in older patients. And we aren't going to talk about benzodiazepines for the treatment of dyspnea. And the reason we're not going to talk about it is that, other than to say that the evidence is still very mixed, and they can carry significant risks, as I'm sure you all know, and they are not routinely recommended. And so we'll focus on the first two categories of pharmacologic therapy. So I talked about the GOLD guidelines earlier. I hear a lot of things about the GOLD guidelines. I will say they are long, they are thick, and they can be hard to tease out and understand, and they keep changing them. So this is the most recent GOLD guidelines, and I'm going to try to highlight the things that I think are helpful to sort of remember. For a long time, the GOLD guidelines and much of COPD care really focused on the FEV1% predicted that we talked about earlier when we were walking through the spirometry. And I had mentioned that that particular patient we were looking at had severe airflow obstruction, which is basically this GOLD 3 category of airflow obstruction. You can see here the breakdown. We basically just look at the percent predicted and break it down from GOLD 1, which is mild, all the way to very severe, which is less than 30% of predicted. I think importantly, thinking about the 4 M's that you all were talking about earlier at the start of this, is that there was a recognition that while FEV1 is an easy thing to measure, it's not actually what matters to patients. What matters to patients is their symptoms and their exacerbations, because those are the things that they're feeling from their lung disease. And so while FEV1 does a good job of predicting overall mortality and things like that, it does not do a good job of predicting functional limitation for patients. And so that is why over the past 10 years or so, with varying iterations, GOLD has really started to focus on this categorizing patients as groups A, B, C, and D. And they used to have the airflow obstruction severity as part of this ABCD classification, and they have moved completely out of taking it out of that, and now just focusing on symptoms and exacerbations. I don't think it's important to necessarily know the different symptom categories, other than to know that patients that are on the left side of this box have less symptoms, and those that are on the right side have more symptoms. And so that's what defines if you're A or C or B or D. And then your exacerbation history is also incorporated into these quadrants, so that people are either less frequent exacerbations, meaning that they don't have an admission in the past year for a COPD exacerbation, or they're frequent exacerbators, which mean that they have 2 or more outpatient exacerbations or at least 1 hospitalization in the past year. So that patients that are in GOLD group A, and I should have said 0 or 1 exacerbations not leading to hospital admissions. So patients that are GOLD group A have few symptoms, and they've had at most 1 outpatient exacerbation. So these are the least severe. And then you move up in severity till you get to the D group, which is those that have the most symptoms and have been either hospitalized or had 2 or more outpatient exacerbations in the last year. And this is what we use to guide what our recommended inhaled therapies are for patients with COPD. So like I said, they've really moved a focus to trying to treat symptoms and exacerbations. So the goals of inhaled therapy are to improve symptoms of dyspnea, exercise tolerance, and health status, and reduce outpatient exacerbations and decrease hospitalizations. Mortality does not come into this. That's why I was saying smoking cessation is the only thing that improves mortality, that and oxygen for people who require it. But these inhaled medications only are to do these 2 things. There's some newer data that suggests maybe there's a small mortality benefit with some of the medications, but for the most part, it's really focused on treating symptoms and exacerbations. Many of you will be familiar with the very many inhaled medications that there are. I think it's easier just to sort of break it down into big categories. So, important to remember in COPD is that the mainstay of therapy should be bronchodilators. These are short-acting bronchodilators like albuterol that you're very familiar with, and ipratropium, or the combination of the two, or they're long-acting bronchodilators that are broken down into basically long-acting forms of albuterol, which is long-acting beta agonists, or anticholinergic, long-acting muscarinic antagonists is the LAMA, is how people refer to them, as LAMA or LABA. So this is tiotropium, which many of you will know or know by its trade name of Spiriva. Those are the long-acting bronchodilators. There's only 2 classes of them, and then there are newer ones that are the combination of the 2 together. And they all have a whole bunch of long names, but basically are a combination of those first 2. So we call those LABA-LAMA combinations. And then there's anti-inflammatory medications, which are, for the most part, inhaled corticosteroids, which we'll talk about, combined with these bronchodilators. And then there's some others like oral steroids that you're familiar with, and a medication called roflumilast. So I think that one of the things that gets confusing about COPD versus asthma is that these anti-inflammatory medications, including the inhaled corticosteroid and its combination with LABAs, are first-line therapies for asthma, but they are not for COPD. And they're in fact second or third line for COPD, whereas bronchodilators should really be your mainstay of treatment for the inhaled medications in COPD. I'm sorry that Teams is popping up. I can't make it stop. I apologize. The benefits of bronchodilator therapy for patients with COPD really comes down to understanding a little bit of the physiology that you can see here for COPD. There is classically the hyperexpansion that people may have heard about that happens in COPD. This is a schematic of a normal lung on the right lung on the left side of your screen, and a COPD lung on the left. And typically what happens is that you have obstruction of the airways that leads to difficulty exhaling fully. So you get some auto PEEP within the alveoli themselves. That causes hyperexpansion of the lung and flattens out your diaphragm. And you have at the same time reduced lung and chest wall recoil. You get hypertrophy of your accessory muscles. And so you have a COPD lung over here and a normal lung here, where you have normal recoil and easy airflow out. The bronchodilators work to combat the physiology of what's going on here. It improves your FEV1, decreases your dyspnea and your dynamic hyperinflation, and increases exercise and functional capacity, and improves overall quality of life. Bronchodilators also reduce the use of additional medication and reduces exacerbations. Inhaled corticosteroids, as I said, are the anti-inflammatory agents, and they are never used as monotherapy for COPD in the absence of a long-acting bronchodilator. We'll talk more about when they are indicated, but their benefits and risks have to be carefully balanced, and should only be used in patients who continue to have exacerbations despite having bronchodilator therapy. And the reason is that their use comes at a cost of an increased risk of pneumonia that we're trying to avoid, particularly among older patients. So this is that same A, B, C, D category that I showed you before in the gold groups. That there is, you've got your symptom assessment on the bottom and your exacerbation over here on the y-axis, and you have grades A, B, C, and D through the gold groupings, the A, B, C, D criteria. And if you're going to remember anything, I will say this is a simplified algorithm of how to treat COPD, and it's a combination of what the GOLD guidelines actually say and what the American Thoracic Society guidelines actually say. And it's what I do in practice and what I think many of my colleagues do in practice right now, which is that when you have a patient who has few symptoms and has not had a recent flare, a bronchodilator is probably indicated, and that bronchodilator can be a short-acting bronchodilator in most cases that can be used on an as-needed basis. Once you move into more symptoms, so that patients have more symptoms, and I should have said earlier, although it's not all that important, what the breakdown between the two, the Modified Research Council dyspnea score and the CAT score are. This is basically people who have to walk slower than other patients the same age or get short of breath when walking up just a short hill. And so when people start talking to me about daily symptoms of dyspnea that is impairing their functional status, they're moving into this more symptom category for me. And the GOLD guidelines would say you can start with one long-acting bronchodilator and you can make a choice here. The American Thoracic Society guidelines are a little bit easier in that they just say everybody should just get dual long-acting bronchodilators. They should have both a LABA and a LAMA prescribed here and basically all the way then through. Once you have significant symptoms, you should just be getting long-acting bronchodilators. And it's only this group D patients, the ones that have frequent exacerbations and lots of symptoms, where you should even start thinking about having an inhaled corticosteroid. I will say this is not what happens in practice. There's a lot of people that are on inhaled corticosteroids that don't have an indication. And the problem with that, as I mentioned earlier, is that it increases their risk of pneumonia. There are some exceptions. You can add that steroid in earlier if people also have a history of asthma and if they have a high eosinophil count, which suggests a more allergic type reaction, then those corticosteroids can be brought in a little bit earlier. I'm sorry, this is a VA problem that the internet keeps trying to make me restart it. So the inhaled corticosteroids can be brought in specific circumstances, but for most people, it will only be if you've exacerbated past your bronchodilators. So, and this is just a slide for you to have that just sort of talks about this. This is the meta-analysis that are presented in the American Thoracic Society guidelines that just highlights why they emphasize this combination LABA-LAMA as the first line therapy for patients that are symptomatic with COPD. And they compared using both bronchodilators together to using either one or the other by itself, and found that over 24 studies with 45,000 participants that you do see improved symptoms, decreased exacerbations, and decreased hospitalization, and improved health-related quality of life. So these are the outcomes that we think are important to patients, and you probably get more bang for your buck if you use both long-acting bronchodilators together. And if you can get it in a combination single inhaler, it is preferred because that obviously reduces the complexity and burden for patients. But it is important to remember that these trials excluded older patients, like we talked about earlier, and often those with multiple chronic conditions. And it doesn't include people who also have asthma, which is why there's that caveat for that group of patients. So when you're managing COPD and trying to treat symptoms and exacerbations, we talked about sort of reviewing in the beginning those things to group people into the ABCD category. And then you're going to start their primary treatment, which most often is going to be at least one long-acting bronchodilator, if not two. And then the next thing that's really important is to see how they're doing with that. And assessing inhaler technique And incorporating the non-pharmacologic approaches that we're going to talk about next is an important piece of that. And once you've satisfied that you're doing those non-pharmacologic things, as well as that they have adequate inhaler technique, then you're going to want to adjust. And you're either going to escalate their inhaler therapy, switch their inhaler device, or de-escalate. And those are the things that we will talk about next. So escalation, as I said earlier, would be addition of a steroid to someone who's already on long-acting bronchodilators. The primary purpose of that would be to reduce exacerbations. And this, again, is just the data from the American Thoracic Society guidelines that looked at a meta-analysis of 4 studies. And I think the take-home points that we want to focus on is that steroids in this group, when you compare using the bronchodilators alone, using the bronchodilators with a steroid compared to using the bronchodilators alone, that you do see decreased exacerbations by 1/3. But there's no difference in hospitalization or dyspnea. You do see improved quality of life. The benefit versus risk is that it increases your risk of pneumonia by 40%. And so because exacerbations for a group of patients who have already exacerbated in the past is at least 10 times more that of pneumonia, then the benefit for frequent exacerbators probably does still outweigh the risk for appropriate patients. But if you've got patients who haven't been exacerbating, this is why the risk is not worth it. And that risk of pneumonia, especially for older patients, is not insignificant. And so it's why we try not to add the steroid if we don't have to. If you do add the steroid, there are combination triple therapies that are available and are on formulary in some places, not at the VA, that you can do. Otherwise, you're using multiple inhalers. This just emphasizes that point of that if you're going to think about adding an inhaled steroid for someone who has already long-acting bronchodilators on board, that if they've had prior hospitalizations or a lot of exacerbations, that's going to be in strong support of adding the steroid. The eosinophils and the asthma we talked about as well. It's going to be strongly against it if they've had repeated pneumonia events or history of things like mycobacterial infection that will be increased with that steroid. And then there's some in the middle where there might be some gray zone, and this is where a pulmonologist might be helpful to help you with that, is to figure out if they've just had one outpatient exacerbation or if they're in the middle of where the eosinophils are. We talked about assessing inhaler use, and that one option for someone that's poorly controlled is to escalate their inhaler and add that inhaled corticosteroid. A second thing that you can do, and this is something that I can't overemphasize the importance of, is you can switch the inhaler device. And this is the overwhelming picture of all the different inhaler devices there are for all of these inhalers, which I'm sure many of you are familiar with, and becomes overwhelming to patients, especially as they switch from one to the other. These are the nebulizers, which are simpler for people to use, and sometimes for older patients are all they can actually. For really frail elderly patients, the nebulizer sometimes is the best option, even though it doesn't allow long-acting medications. So I thought it would be helpful to sort of just cover the main types of inhalers and some troubleshooting that you might need to do for your patients with using them. So the newest inhalers and the ones that many of our patients are going to be on are called the Respimat inhalers. This is the slow moving mists. And the advantage of these are that it literally comes out as a mist, and it's much better chance of reaching the small airways for patients where we need it to go. And the combination, these are long-acting inhalers. You see tiotropium and olodaterol, and then the combination of the two. Those are Respimat inhalers that are what I try to use as my primary treatment for all my patients. The disadvantages that we have to remember is that these devices, while they're easy to take the mist itself, it's not that easy to prepare the device for patients. You have to turn the canister for each dose to get it to click in and give you the medication. It's small and it can be difficult for patients to see the small numbers and the dosing, and it does require more coordination than the dry powdered inhalers that we'll talk about in a minute. And so it's not completely fail safe. And so it's important to make sure that your patients can actually use these appropriately, because if they can't get the device prepped, then they're not going to get the benefits that we talked about. And sometimes it's just they can't do it. The meter dose inhaler, this is the one that all the albuterol inhalers are, the short acting rescue inhalers. This is a pressurized canister that has the solution in suspension, and it's got a gas propellant. And the advantage is that it's compact, it's portable, it's consistent, it's fast acting, faster than the other ones, but it's also really complex. In that it takes a significant amount of coordination, particularly hand-mouth coordination, to get the medication delivered appropriately. And so a lot of it ends up in the back of their throat. And this study just sort of emphasizes that this is MDI use and looking at the fact that it takes 10 to 14 coordinated steps to use. I will tell you that the steps are different depending on what you use, but they include things like taking the cap off of the inhaler. It is in there, but you have to take the cap off. You have to hold the inhaler away from your mouth. You have to exhale completely. You have to fit it in your mouth appropriately. You have to time your breathing appropriately. Make sure you press it at the right time and then exhale appropriately as well. And so when they did a meta-analysis of 24 studies, there were 77% of patients that had at least one error with taking these types of devices. And inadequate hand-breath coordination and poor fine motor control were particularly problematic. And when you look at rates of successful use, you could see, unfortunately, that when you look at age over time, it decreases dramatically as you get older. Reassessment and retraining is really important for patients. In this study of 30 independently living, cognitively normal volunteers that were aged 73 to 90, 97% could learn to use it correctly. And then 24 hours later, only 36% could do it correctly, getting all the steps. The good news is you can use a spacer, which is a device that will help where they don't have to get all these coordinated steps right, and they can still get most of the medication. Or you can use a nebulizer for these short-acting medications, and so that is often a really fantastic solution for our older patients that aren't going to be able to coordinate their rescue inhaler. And then the last main type of device is the dry powder inhaler. This is a breath actuated device that you inhale the medication in the dry powdered form. The advantage is it doesn't require the same amount of coordination of inhalation and activation. You can see these ones, though, for the most part, are those that these are with the exception of the tiotropium hand inhaler, these are the ones that include the inhaled steroids. So most of those inhaled steroids are in one of these combination devices. The issue is that you have to have more inspiratory flow to actually get the dry powder into your lungs. So for people with severe lung disease, I just talked to a patient today that was doing fine on a different inhaler, but when he switched to this type of inhaler, he doesn't feel like he actually gets it into his lungs and and that's probably true because his lung function is so bad that it's difficult for him to get it in. It can be harder for older people to get the medication delivered. And then some of them have blister packs like this tiotropium inhaler, and that can be hard to get the capsule out. So this is all to say that it really does depend. It's important to know what the delivery device for your patient's inhalers are, because you can try to troubleshoot some of this and change their inhaler up to get them the medication that they need. And then lastly, I'll just say that, we talked about escalating therapy. We talked about switching inhalers, that there's also time to consider de-escalation of therapy or withdrawal of inhaled steroids. And it's important. They've done studies that basically say, if you've had no exacerbations in the past year and someone's been stable on their triple inhaled therapy, that you can consider an ICF withdrawal trial. And this is the American Thoracic Society guidelines again that show that it's safe to do that it doesn't increase any adverse events. And there's a statistical decrease in quality of life, but not a clinically significant one. And so the recommendation is if someone's been stable, maybe they don't need their inhaled steroid anymore, and you can reduce their risk of pneumonia maybe over time. So I'm keeping an eye on time and I want to leave time for questions. And so I'm going to quickly go through that. We talked about adherence can be challenging, especially among older patients. This is a table that shows a number of different studies. And you can see that unfortunately, adherence just overall was poor in many of these studies, particularly among patients who were over the age of 65. It's for the reasons that we talked about before, and that we have to remember that sometimes they'll have cognitive impairment, other comorbidities, and polypharmacy that all play a role into this adherence. So it's just important to talk to your patients about their adherence and try to encourage it. The side effects are also something that we have to consider more in older patients. Each of these medications that we've covered so far has its own unique side effects. The beta 2 agonists are known to cause resting tachycardia if they're used. I would say I most often see that if used in large doses. So my patients who come in and say they use their albuterol inhaler 10 times a day, they might get tachycardia and some increased tremor. There Some people would say you can try to use a different formulation of albuterol that may have a little bit less of that. It hasn't borne out over time in a lot of studies, but it is one option to try. And I've had some success for patients who have tremor with albuterol who do not with levoalbuterol. The antimuscarinics, which are both the short-acting ipratropium and the long-acting tiotropium type medications, you'll often hear about dry mouth. Urinary retention can be an issue, although there does not seem to be a causal relationship. There's been a lot of debate over the years about cardiovascular risk, which it seems like is not with the long-acting tiotropium. If you use it with a face mask, which none of my patients do, there could be some precipitation of glaucoma. In general, they're considered safe and they've got low overall absorption, so you shouldn't have as many anticholinergic side effects as you do with pills. And then the inhaled steroids, like we talked about, there is high quality evidence of a number of side effects, the most important being pneumonia, but also some variable evidence about decreasing bone density and increasing fracture risk. And there's some observational studies about poor diabetic control. And so again, it just emphasizes that side effect profile is not positive and that really it should just be among selected patients. So to sum, I thought it might be helpful to have some take-home points for these inhaled medications. For symptomatic patients, combination LABA/LAMA as first-line therapy. Most people would recommend. For some people, if they don't have exacerbations, you could consider monotherapy with just one or the other. If you have frequent or severe exacerbation despite the LABA/LAMA, then consider adding an inhaled corticosteroid into the mix. Remember to consider their prior pneumonia events and make some shared decision making about the risks versus benefits. And then you can think about that earlier if they have these comorbid asthma. For all patients, make sure you're considering the potential side effects that may increase with age and then adapt accordingly. And remembering training and retraining on inhaler devices is really important. And if they can't master it, try an alternate because there is a number of different delivery devices. If they're using a metered dose inhaler like albuterol, consider a spacer or nebulizers. And then remember to de-escalate when you can. And not to use inhaled steroids alone or if they don't have an exacerbation history. This is just a comment to say that maintenance therapy with chronic corticosteroids, which many of my patients ask me for because they take prednisone for short bursts and feel like it helps them, and then ask if they can be on a low dose of steroids for a long period of time, just know that that is not recommended. This is again from the American Thoracic Society guidelines, and it's because the evidence does not support giving chronic low-dose oral steroids for patients. It doesn't improve mortality, exacerbation risk, shortness of breath, hospitalization, and it has a number of increased adverse events that I think many of us are familiar with the use of long-term oral steroids. And so they do give a caveat that it could be considered. I would say if you're considering, that might be the time to involve a pulmonologist. I think in the interest of time, you have these slides. I'm going to skip over azithromycin and roflumilast. I'm going to say that these are advanced therapies that are oral medications that can be used for patients who continue to exacerbate despite optimal inhaled therapy. And if you're thinking about using azithromycin or roflumilast, that is probably time to refer someone to a pulmonologist, largely because that means they've got refractory disease that's continuing to exacerbate despite the evidence base. And remember that azithromycin, um, while it seems benign because it's a chronic antibiotic therapy, in studies did lead to a fair amount of hearing loss, and can lead to QT prolongation. And so it has to be monitored carefully, especially in older patients. Sorry, I didn't mean to skip this. So I promised I would talk a little bit about advanced refractory dyspnea and the use of opioid-based therapies. Um, this again is from the American Thoracic Society guidelines and the meta-analysis that they did, which was 14 RCTs, but only 366 participants, and showed that opioids show no difference in a number of outcomes, including exacerbations, ED visits, but also falls or overdoses. And there was a significant improvement in dyspnea that exceeded the minimally important, clinically important difference, but no difference in exercise capacity. And so I think this is a really individualized choice, and that in particular patients, particularly those that are focusing on quality of life and palliative measures, the balance of benefits may indeed outweigh the risk, and it just needs to be a very careful shared decision making that goes on between patients who have advanced lung disease, who are going to be at increased risk of things like carbon dioxide retention, but a well-informed patient and a good discussion about the risks and benefits. um, it does result in an improvement in dyspnea based on the evidence. This is a interesting article that I just want to point out that was published in JAMA Internal Medicine that gets a little bit at this idea. Anand Iyer is at UAB, and Randy Curtis, who's here at the UW, wrote a viewpoint tweet about the proactive integration of both geriatrics and palliative care into the practice for chronic obstructive pulmonary disease, which I think is super important. And they advocate in this article about the idea that how it can improve overall care of COPD to integrate both palliative care and geriatric specialists like yourselves. Widespread education on anticipatory symptom management, teaching clinicians on how to communicate with patients and family, how to identify complex symptoms and functional needs, and how to integrate these skills to, which includes the safe and appropriate use of low dose opioids to prevent dyspnea crisis, is really important. And so we'd like to see more of this integration over time. We're going to get to our last two topics now. And I think in the next 15 minutes, we're going to talk briefly about pulmonary rehab and supplemental oxygen, and then open up time for questions. These are the non-pharmacologic therapies that we talked about. Multiple randomized trials have shown the benefit of pulmonary rehab, so we're going to talk a little bit about that as well as the barriers. And supplemental oxygen has excellent evidence in randomized controlled trials for specific patients, and knowing which patients those are and how best to treat them is an important part that we'll talk about. We are not going to talk about surgical options. When you're talking about surgical options for non-pharmacologic therapy, it's good to know that they're there, but these are things that, again, you'd be referring to a pulmonologist before you were doing. And I'm going to just mention that there are other non-pharmacologic therapies that are mentioned in this review article as well. And some of them that we do use, such as blowing cool air in fans to treat dyspnea, that has some evidence to support it, and a therapeutic trial is probably justified given minimal morbidity. But we just don't have tons of evidence to support that, or things such as acupuncture. There is good evidence to support nutritional support, especially among older patients. You can improve quality of life and respiratory muscle strength. So incorporating our nutrition colleagues into patient care is very important. So pulmonary rehab. So many people have heard about it. Not many participate in it. As I said earlier, pulmonary rehab is more than just physical therapy for patients with COPD. It's actually a comprehensive intervention that's tailored to the patient and includes exercise training, and in traditional in-person programs is supervised exercise training that occurs at least 2 times per week. It includes both endurance and strength training, education, and self-management. And it lasts usually 6 to 8 weeks. So it's a pretty intensive program in person, and it has great results. And it is known through multiple randomized trials to improve dyspnea, reduce symptoms of anxiety and depression. It improves health status, exercise tolerance, and in some smaller studies, decreases rates of 30-day readmission, which at the start of the talk I talked about is such a huge problem. The issue is the low uptake, and there's a lot of reasons for this. Some of it is the intensiveness of it. Some of it is the availability of programs. Some of it is the lack of knowledge that people have about where these programs are and where you can get it. And in at least one study of more than 200,000 patients that were hospitalized with COPD, only 2% got pulmonary rehab within 6 months. And that's pretty consistent. It's somewhere in the low teens at best of patients who get pulmonary rehab. I alluded to this before. There are multiple barriers that we talked about. Again, it's not lack of knowledge that pulmonary rehab is necessarily good. It's more about where do you go? How do you get people into it? How do you get it approved? Patients play a huge role in this, and that if the program is far away, the distance and mobility becomes problematic, especially because patients with COPD tend to be elderly, lower income, often live in rural areas. It can be really hard to get to pulmonary rehab. There's also social barriers, timing, and then there's the clinician factors of sometimes we just assume our patients wouldn't do it, and so we don't recommend it to patients, or they might not feel like it's going to be as helpful as it might be. And then there's a big problem with there being insufficient number of programs to serve all the patients that might potentially benefit from it. And then that has all been, of course, compounded in the setting of COVID. It's hard not to talk about that. Going to inpatient pulmonary rehab hasn't been an option for most of our patients for the past 2 years. Telehealth has a lot of promise in this area. I would say we don't have as much data as we will in a couple of years about this. There's a number of ongoing studies that are looking at telehealth as a way to deliver pulmonary rehab. I know there's been a lot of this within the VA and other programs like with Gerofit and things like that. And so there's a good precedence for these types of programs to be delivered by telehealth, but there just is less data about it in the COPD type population. Surya Bhatt at UAB has published a pilot study of video telehealth, and there's a number of other pilot studies that have also been published in the last couple of years. But this is one study at least that suggests the potential benefit of using telehealth for this. They enrolled patients in a video telehealth intervention after hospitalization for an exacerbation. They excluded people who were going to have safety issues, and then they retrospectively matched them to patients who had historically been hospitalized before this video rehab was there. And they used a smartphone application at a 10-day follow-up visit and used two-way video conferencing. They did an initial outpatient assessment by an exercise physiologist and tailored a plan that they developed. And the patients did 36 sessions over 12 weeks, each 45 to 60 minutes. And it included the same things as a traditional pulmonary rehab program would, including the exercise and the educational sessions. And they had great results. They had 66 of their 80 participants in the telehealth rehab intervention that completed at least 20 sessions, and no adverse events. And this is opposed to 42 patients out of the 160 that were getting standard of care. And that 26% had been referred to traditional pulmonary rehab and only 6% had actually enrolled. So this sort of speaks to the abysmal rates that we get with standard PR and how much better. And they saw some promising results. They actually saw reduction in all-cause readmissions and COPD readmissions. And so this is, as I said, Surya himself has an ongoing multi-center trial of this, and others do as well. And I think that in the future, this will become a much more accessible way for our patients to achieve pulmonary rehab. And there are programs that are ongoing right now, including one here at the VA Puget Sound. Okay. Last, I'm going to briefly talk about oxygen, and then I'm going to open up to questions. So oxygen, what I will say is that everything that we've ever been told about oxygen and how beneficial it is based upon these two studies that were done in the 1970s and published in the 1980s. And they looked at patients, a total of less than 300, who had COPD, and they randomized them throughout the two trials to either getting no oxygen, 12 to 15 hours of oxygen, or 24 hours a day of oxygen. And they very clearly showed a dose response benefit in survival. So that patients with COPD who have a saturation of 88% or less on room air at rest, there is a clear benefit for oxygen. And this is the other thing that improves survival in addition to smoking cessation. The problem is that those two studies got extrapolated, at least the problem in my view, is that those studies got extrapolated widely to patients who were being discharged from the hospital with short-term oxygen therapy, to patients who desaturate when they walk, but are fine at rest, and to patients who desaturate when they sleep, but are fine when they're awake. And in the end, there's now more than 1 million Medicare beneficiaries that are prescribed home oxygen each year, which is about $2 billion annually, which is something to note. And what turned the field on its head a little bit is that finally a study was done published in New England Journal in 2016, which is called LOT, or the Long-Term Oxygen Treatment Trial. And many of you may have heard about this, and some of you might not, but they basically took people, not the people who were in those other studies, not the people with severe resting hypoxemia, but instead those patients that we see that are fine at rest but drop their saturations when they walk, or who had a little less than optimal saturations when they were sitting there, and they randomized them to get oxygen or not. And they looked at, their primary outcome was time to death or first hospitalization, but they looked at 14 secondary outcomes, which ranged from everything from COPD exacerbations to quality of life to functional status and 6-minute walk distance, etc. And they followed them for 18 months, and they found no difference in any of the outcomes with oxygen. And so this has turned the field on its head in a little bit, in that it's created a lot of controversy. There are other studies that have been done on treadmills and in pulmonary rehab that showed people in isolated exercise time improve their exercise capacity if they have oxygen, if they drop their saturations when they walk. But this is the first large randomized trial, and there were 700 patients, so twice as many were in those initial trials, that showed over the long term, it doesn't seem to make a difference. And so different societies have taken this differently. The American Thoracic Society has suggested that patients could still be prescribed oxygen for this indication. The VA and the GOLD guidelines have said it's no longer a routine indication for oxygen, and that it should only be given to specific patients. And so, and if you talk to pulmonologists, they will all have a little bit different opinion. But I think the important thing to remember is that supplemental oxygen has the potential for harm, that many patients still smoke, and the risk of fire is not negligible if you smoke with your oxygen. It results in a number of emergency visits and fires each year, and fires with death. And probably more common even than fires is that, especially for elderly patients, that social isolation that I talked about can happen, and falls are not that uncommon because the tubing they trip over. And then there's also a lot of problems with the use of oxygen itself. In a survey that was published in the Blue Journal, which is the American Journal of Respiratory and Critical Care Medicine, 51% of patients reported problems using oxygen that led to reductions in their quality of life. So it's not something that's completely without risk. And so I think what I would take home from home oxygen therapy is that if you've got resting hypoxemia, you should definitely recognize that there is a survival benefit from being prescribed oxygen. But if you have stable COPD and you drop your oxygen saturations when you drop, or when you walk, you really have to think about individual patient factors. And that while it might improve some breathlessness, it should probably not be prescribed routinely for all patients. And compounding that fact is that adherence to home oxygen is also low among people who get it prescribed, and that the things that are predicting non-adherence are older age and late stage COPD and poor functional status, and things that all of these patients who get oxygen are prone to have. The things that improve adherence is making sure that they've got the right delivery system that meets their needs, improves their mobility, and is convenient. And we don't have a great way to improve adherence for patients. The last thing I'm going to leave you with is the delivery device and the effect it can have on mobility. Some of you may have seen each of these delivery devices before. But just as a reminder, this is a stationary concentrator that all patients with home oxygen probably get. It requires a constant power supply and comes at a higher patient cost, but is the only way sort of that patients, this is what many patients have in their home to sort of meet their oxygen needs over time. The compressed oxygen tank is a portable option that you see here, which is cumbersome and big, but can be used using a home fill system, which is basically this accessory that goes on top of their concentrator. And so they can fill these tanks up from their oxygen concentrator at home, but then they have to kind of lug this around with them. And the flow usually determines how long it lasts, but it usually lasts a couple of hours, but it's not light. And so it's cumbersome for patients to drag around, but sometimes is what they need. And this is the one that can sort of help lead to, unfortunately, falls because of its cumbersomeness. All of my patients want a portable concentrator. It takes oxygen from the ambient air, just like the stationary concentrator. It runs on a battery. It lasts for hours. You can see why carrying this is way better than trying to roll this around with you, and why it's much more portable. The problem is that you really need to have relatively low oxygen requirements for most of these portable devices. Many only deliver them in a pulse flow. Many only deliver them at 2 to 3 liters. And so they may not actually meet the oxygen needs of patients, which limits currently, the technology sort of limits their usefulness for some people. And that's not great news for people that have bad lung disease and need a lot of oxygen because they're stuck sometimes with these bigger tanks. Liquid oxygen is sort of the thing that makes that better. The liquid vaporizes and provides a steady flow. It's lightweight. You can see it here. It lasts longer even at high flows, but it's super expensive. And because of a number of reasons through Medicare, it can be really difficult to obtain right now. It is filled from a home reservoir, but patients have a lot of difficulty getting it. And so these problems with getting the appropriate device that can improve their mobility can be really a challenge, and something that can take a lot of time and effort trying to work it through with patients. Okay, so I'm going to welcome survey questions. I'm going to leave you with these take-home points: that spirometry is an important step in appropriate diagnosis. Elderly patients may require special testing conditions and coaching to get the optimal results. Remember, smoking cessation is always important, and older adults may require more intensive regimens. Dyspnea management requires making sure that we appropriately identify and treat comorbid illnesses in addition to COPD itself. Remember those take-home points about the long-acting bronchodilator therapy for symptomatic patients. Reserve the inhaled steroids just for patients with frequent and severe exacerbations, and try to de-escalate them when you can. Inhaler training is essential, and for a number of reasons, older patients may have difficulty with specific devices, and consider retraining them or switching them if needed. And shared decision-making regarding risks and benefits for individual patients is important. Low-dose opioids probably have a role, and an important one, in palliation of refractory dyspnea. And integration of pulmonary, geriatric, and palliative care can improve care management. Remember, pulmonary rehab, it improves outcomes. There's a lot of barriers for in-person programs, and telehealth modalities may offer potential promise, and we're getting more evidence on that now. And long-term oxygen therapy is indicated for patients that have resting hypoxemia. You don't have to routinely use it in patients that just drop when they walk, and it does have associated harms that have to be considered. But ensuring patients get appropriate oxygen devices that increase their mobility is an important piece of home oxygen prescription. That was your whirlwind COPD care. And I welcome questions.
Thank you so much. That was just incredible. I really appreciated both the breadth and the depth and the practical guidance. So thank you, thank you, thank you. And I actually wasn't seeing the pop-ups, so maybe it was just on your end, Dr. Feemster.
Oh, good. I'm sorry, because I kept getting these pop-ups to renew my, thank you. I'm glad.
Yeah. So a question about any recommendation on how slowly to withdraw ICS if stable with no exacerbations in the past year. Does it need to be tapered slowly, or can it just be abruptly withdrawn?
Yeah, so I would say the Wisdom trial is the one where they looked at withdrawal of inhaled corticosteroids. And in that study, they did taper it down. I would say our experience, we've done a number of studies here, decreasing steroids, and we've gone back and forth with tapering it or not. Sometimes it's just super confusing because the issue is you go from a combination inhaler to then adding a new inhaler that's just the steroid by itself, and then you have to taper that down alone. Sometimes that is just not worth it. And so what I have now moved to is if someone is on a low dose steroid, I just take it away. So if they are an instant budesonide formoterol, which is commonly known as Symbicort, comes in two formulations. It comes in an 80 and a 160. And if they're on the low dose one, I just stop it. And if they are on a higher dose of steroid, those are the people that I consider whether or not I should taper it. And in those patients, I do. I end up switching them over to a combination LAMA and adding a lone steroid inhaler and then going down slowly on it over 2 to 4 weeks. There's no exact regimen, but the Wisdom trial is one where they did taper it. And then there's other studies where they just stopped it. So I would look at the patient and see if they've never had any exacerbations and the steroid never really did anything for them, and they're not actually adherent to it, which many of them are not, then I just stop it because it's just easier. Otherwise, you can taper it slowly over 2 to 4 weeks. And the pharmacists are a great resource. I always go to them to ask them what I should do for specific things.
Great. Another major factor to consider regarding the complications, you had talked about this earlier, of opioid interventions is fall risks. And so Lisa's just mentioning that those kinds of falls can drastically change the course of someone's life, particularly at the end.
Oh, yeah. I totally agree. And that's why I think involving palliative care and geriatric specialists like yourself is an important part of that. I as a pulmonologist, I rely on my geriatric and palliative care colleagues to help me know when the right patients to add those are.
And Lisa's also wondering if there are clear physical changes to the lungs or diaphragm in COPD, why imaging is not possible versus spirometry.
Yeah, that's a great question. So it's like I planted these things. There is a lot of work ongoing right now, looking at using quantitative CT scanning to quantify emphysema, as opposed to using spirometry. And what it comes down to is that while we are developing those modalities right now, there have not been the trials done of showing the benefit of the inhaled therapies for patients who have, for instance, emphysema on CT, but don't meet criteria for airflow obstruction. So all of the randomized trials of the inhaled medications have been done in patients who meet spirometry criteria for COPD, and we are investigating what to do about these other patient populations. But I think that's where the future is going. For what do you do about emphysema on CT? Do you treat it the same way? And the diagnostic conditions might change over time. There's also this thing called PRISM that many of you might have heard about, which is preserved lung function despite having smoking. And those people still have a lot of respiratory symptoms. So ongoing research right now.
Linda's wondering, does secondhand smoke exposure for 10 years in a person's 20s and 30s make a person high risk for pulmonary problems as an older adult?
I think high risk would be relative. I would say that I have patients that I see in my pulmonary practice. I just saw an 86-year-old woman today who never smoked in her life, but has emphysema on her CT scan and clearly has COPD and had significant secondhand smoke exposure when she was younger, and then also had an additional inhalational injury when she was in a house fire. So I think it's very individual specific. And so if they had that smoking in their 20s and 30s and now they're 70, and they haven't developed lung disease by that point, they're probably not going to. But there are people who have just really intense secondhand smoke exposure that will go on to develop COPD.
And Dr. Feemster, do you have time for a couple more questions?
Yeah, I do.
Okay,
yes,
great.
Of course.
So Gigi said, thanks so much for a very informative talk, and is wondering about your thoughts on nighttime CPAP treatment for advanced COPD patients, variables to consider?
Yeah, I think that's a great question. So CPAP, continuous positive airway pressure, should be differentiated from bilevel, which is two different pressures, an inspiratory pressure and an expiratory pressure. So CPAP is helpful for sleep apnea. So patients who have COPD, there is a significant overlap with sleep apnea. And so if they have signs or symptoms of sleep apnea, so snort arousals where they wake themselves up, significant snoring, obesity, and daytime fatigue, headaches, all those sorts of things, then doing a sleep study looking for obstructive sleep apnea among patients who have COPD is recommended. And then CPAP would be the first line therapy. Separately, there's BiPAP, which is the difference where you have a high inspiratory pressure, basically usually, and a low expiratory pressure, which helps with ventilation. And so that is what has been studied in just COPD in the absence of obstructive sleep apnea, which is does adding bilevel ventilation, basically assisting ventilation at night, help. And there is some evidence to suggest that in patients who have severe COPD and chronic CO2 retention, so who have a blood gas that shows elevated PCO2s in above the 40-45 range, that doing pretty intensive titration of bilevel can reduce their carbon dioxide retention over time. So that's a time when I would be referring them to a pulmonologist to sort of do those more advanced maneuvers. And so there is some evidence to suggest bilevel for some patients.
Okay, well, I think the last one that I thought was a question was just saying, thanks so much for such an informative talk. So, and someone said this was really the best presentation so far as a non-practitioner. This information was presented in a way that's very accessible for lay public. And one more question just popped up from Mary Zeitner. Is there any assistance for Medicare patients who cannot afford their inhaler, and definitely not any added oxygen?
Yeah, that is, such a great question. I have to say I'm a little bit of a disadvantage because I operate out of the VA for the most part. So my clinical experience with that is less. I will say that the inhalers are a huge problem, but, and they are expensive. There are usually older generic. I think what you'll end up doing is trying to, instead of using these newer combination inhalers, you'll end up using mono inhalers that you then have to use multiple of, which is not ideal. Sometimes the pharmaceutical companies will have sort of coupon programs and things like that. The oxygen, Medicare will cover as long as they meet criteria for it. They just won't get them the oxygen they want. They will cover that stationary concentrator and the compressed gas. And this is all part of this competitive bidding mess that many people have written about and talked about. But it's going to be hard for them to get liquid oxygen or a portable concentrator in some cases, but they will supply them with oxygen that is affordable. It's just not as convenient and helps them with their mobility as much as we would like. So there's a lot of advocacy going on about improving oxygen for patients. So that may change over time.
Okay, well, thank you so much. Really
Oh, thank
appreciate this
you.
content. Everyone have a nice evening, and I will see you next week.
Thank you so much.
Thanks.